Hey guys, Jimbo here. I'm a otolaryngology or ENT resident, and I just wanted to put a talk up on YouTube for why I think ENT or otolaryngology, I guess technically some call it otorhinolaryngology, to oto ear, rhino nose, larynx, voice box, throat, is such a phenomenal specialty. In fact, in 2018-2019 application cycle, it was the most competitive specialty according to an article by the AAMC. Their criteria for competitiveness was the percent of spots filled by U.S. allopathic seniors. So, in other words, in ENT, 94% of the residency spots were filled by MD applicants that were seniors out of U.S. MD schools. So DO would not count for this. Somebody coming out of the Caribbean wouldn't count for this, or somewhere in Europe or wherever. And so that's one perhaps snobby way of measuring competitiveness, but that's how the AAMC did it, and ENT came out on top for that application cycle, with a lot of people tying for second: plastics, thoracic surgery, neurosurge, and orthopedic surgery. So hopefully I'll discuss why so many people want to get into this. I love my job. I think it's great, and we'll see if I can articulate that not half bad. So, with ENT, there's a broad scope of practice, and the reason is we're dealing with a region of the body, not just one system. We are dealing with the head and neck. Some people will say pleura to dura. In other words, we go down in the neck, down by the clavicles, where the top of the pleura is coming. Sometimes when we're doing some thyroid goiters that get close down into the chest, or we work with thoracic surgery, we can see the lungs going up and down, and if we're not careful, we can definitely cause a pneumothorax. And then lots of times in ear surgery and up in nose surgery, we can be drilling through the skull base and see the dura, or sometimes we work with neurosurgery to go through the dura or patch the dura. So everything in this area we are managing. A few exceptions. We do not do the spine or the spinal cord. That would be ortho and neurosurge. And we do not do the brain. Usually, if we pop into and cause a CSF leak when we're doing stuff in the ear or the nose, we'll try and fix it ourselves or call in neurosurge to help us. Oftentimes, we have to work with neurosurge to get tumors out in this area. And then finally, the eyeball would be off, though. We're very often in the orbit, but the eyeball is off those world. So it's cool that you got a lot of things going on. And what that means is we interact with muscle. We interact with endocrine tissue like the thyroid and the parathyroid. We interact with a lot of vasculature, and you can go into microvascular anastomosis. We interact with pretty much all of the cranial nerves. Not pretty much, we do interact with all of the cranial nerves, and we're interacting with bone. So you're working with most of the tissues of a good chunk of the tissues of the human body within our subspecialty. Um, you can go into many different subspecialties. You just want to do ear, you just want to do nose, you just want to do throat, you just want to do aesthetics, you just want to do cancer. You can do that. However, I do appreciate that within this field, many are still generalists. For instance, in orthopedic surgery, if you're going into private practice, most people still do a fellowship. Whereas most of the people in private practice ENT are generalists, which is kind of nice. If you love doing sinus surgery, but you also love doing ear surgery and some easier cancer surgeries, you can do all of that within your practice if you feel comfortable. We'll talk about how we use pretty much every surgical modality. We use the microscope, we use endoscopes, we use we do image guided surgery. We do big open surgeries, etc., etc. So it's nice to have all that. We use the robot as well. And it's good because it's a field where it can be lifestyle friendly. Some call it ENT for early nights and tennis. Or you can be super rigorous and do a ton of cancer surgery or whatever other type of surgery that you want to. It's really up to your choice. There are practices that are gnarly. There are practices where you could have a 4-day work week. So the choice is yours. And then one nice thing I think is that the majority of surgery is outpatient. Why is that important? When you're a resident, most of the gen surg or urologists or neurosurgeons, where they have a bunch of inpatients, they'll be rounding around 5 a.m. Whereas I feel that most of the time I'm coming into the hospital maybe at 6 a.m. for some 6:30 rounds, etc. Just because we don't have a giant census of patients to visit. And so that makes your life a little bit easier. Moving on. Another thing I love about ENT is that clinic is very procedural. So lots of times in clinic, people come to you with throat complaints, whether that be cancer, dry throat, change in voice. So what we'll do is we're looking at the larynx. So this is called laryngoscopy, and this is flexible laryngoscopy because we're taking a fiber optic camera, putting it through someone's nose back to their nasopharynx and using that to look down here at this anatomy at the base of the tongue. You can look at the soft palate. You can look at the posterior pharyngeal wall down into the the larynx, and the esophagus would be back here. So here's anterior. You can see some little nubbin there in the left vocal cord that they are examining here with flexible laryngoscopy. So you often do that when you're in clinic. Also, we deal with a lot of things in the neck, and ultrasound is a nice modality for assessing things in the neck. So we can assess lymph nodes in the neck in case there's cancer or they're just reactive to some infection. And then, of course, we have the thyroid and parathyroid glands here in the neck that we can assess for cancer or hyperparathyroidism or all those pathologies. So you're imaging things in clinic. This is a flexible scope. This is a rigid scope. And so this is rigid endoscopy of the nose, rhinoscopy. And you can look inside, you can suck out boogers and send them for culture. You can debride things. Some people will do in-office ablations where they have too much nose tissue that's making it hard for people to breathe through their nose. So that's a cool procedure. And then we also use the microscope in clinic. So here is an ENT using a microscope to look inside this patient's ear. They have a speculum in there to get a good view of their eardrum, and then you might take some alligator forceps and pull out something nasty like this ball of earwax. The patient will be awestruck that all of that was inside their ear, and sometimes they may hear significantly better and be super happy. So it's cool that when you're in clinic, you're not just taking a history and doing a physical, you're very often doing procedures that are moderately invasive, going in here, going in here, going in here, using cool technology like scopes, whether they be flexible or rigid, ultrasound, and microscopes. I mentioned that we have a wide array of surgical modalities. So we do nice big open procedures with a good old 10 blade or a 15 blade. So here would be an example of a neck dissection where we go in typically to remove the lymph nodes that are along the jugular vein and other areas that could be sites of metastasis for cancer. So here you can see the jugular vein, you can see the carotid artery, the ventral strap musculature, etc. So you get nice big open surgery. We also use the robot. So here's an example of using the Da Vinci. Here would be the console over here. And this is advantageous for dealing with pathology that's back in the oropharynx area, where doing it with just your hands would be a little difficult. We also do microscopy for microvascular repair. So this would be an example of, let's say this is an attending and this is a fellow, and we'll talk about flaps later where they're maybe putting an artery from an arm where they took a flap from an arm and they're plugging it into an artery in the neck, and then they're using that flap to reconstruct half of a tongue that had to be removed for tongue cancer. So you operate under the microscope. And then we use lasers, both in the ear and this would be an example of in the larynx where they're using a laser to deal with some pathology on this patient's right true vocal cord. And then this is a kind of a poor picture of using image-based guidance in your surgery. So this is somebody using, again, a rigid endoscope, and they're going into this patient's nose to deal with some pathology. And the camera system here, or sometimes the tool you're using, is integrated with CT scans or MRIs that were performed pre-op, so that we know where on the scan our instruments are working. This is important because lots of times in the nose, people might think, oh, nose surgery, no big deal. But we are within millimeters of busting into the cranial cavity. So it's really important when you're around the skull base to know exactly where you are to make sure you're not popping into the cranial cavity or popping into somebody's orbit. And then here's another example of the microscope, however, this being used for ear surgery to get nice detail when you're trying to help somebody hear or get rid of something that may limit or damage their hearing. So there's a decent amount of fascinating physiology. Um, this is a rotary chair, and there's lots of things that we can do to assess somebody's vestibular system within the inner ear. You'll do this and get a bunch of outputs, and you can work with audiologists to figure out why a patient may be dizzy. There are lots of things that can cause dizziness, but one of the things can be pathology within the inner ear. Another thing is we learn how to read audiograms where they essentially assess why a patient might have some hearing loss, where um, things have to be at higher decibels in order for them to hear them and differentiate them. And you get pressure waves and different volumes that you can use to narrow your differential diagnosis for this patient's complaint of hearing loss. The vocal cords have pretty fascinating physiology. This isn't a great picture, but here they are abducted or separated, and this doesn't show them adducting, but essentially they come together and they will vibrate, and that is what gives you and I our voice. And then finally, we do deal with swallowing and sometimes do surgeries or other things to try and assist with swallowing, such as somebody if they had a Zenker's diverticulum or other issues. And that's a complex physiology. The soft palate has to lift, the tongue and base of tongue has to push a bolus back, the larynx has to elevate, and the epiglottis has to come down, and then the upper esophageal sphincter has to relax to receive things, to receive the fluid or food bolus. So there's actually a lot of coordination between a lot of musculature in order for people to swallow without aspirating or having issues. So we do have our physiology that we work with. So now going into some of the subspecialty or specific areas of ENT, first we'll do is otology, oto meaning ear, and also the lateral skull base. So kind of the basic things that an otologist might do, or a general ENT, is here we have an eardrum, and here we see a perforation or hole in the eardrum. And so you would perform something called a tympanoplasty to fix this. The tympanic membrane is the fancy name for the eardrum, and so tympanoplasty would be to fix this. Here you can see evidence of something called a cholesteatoma, where you're seeing this keratinaceous debris, and this is essentially, it has actually nothing to do with cholesterol. It's more or less a skin cyst that's grown into the middle ear, and it can become infected and cause chronic infections. It can mess with your facial nerve, it can mess with your balance, it can mess with your hearing, it can cause meningitis if left unchecked. So we have to do surgeries to fix this. It would be an example of more of a skull base issue where, here we have the pons, we have facial nerve number 7 coming out, we have number 8, vestibular cochlear nerve, and oftentimes you might get a vestibular schwannoma, usually coming from the inferior vestibular nerve here at the cerebellopontine angle. And this is a benign tumor, but as it grows and grows and grows, it can cause issues because of its growth. So you might get some facial paralysis, you might lose your hearing, you might start to get dizzy, and there are many approaches. Some ENTs, depending on what the goal is and where the tumor is and whether or not they have hearing, they'll do a middle cranial fossa approach where they will essentially surgically approach the tumor by doing a craniotomy and then lifting the brain up so that they can move along here on top of the temporal bone and get to the tumor, or drill through the top of the temporal bone to get into a tumor. Or they may do a translabyrinthine approach where they come in kind of behind in the middle ear, and then they'll blast through this area called the labyrinth to get approach here. that would lose your hearing, but depending on the tumor, etc., that might be what you have to do. So very often, at a very few places, the ENTs would do all of this, but usually this is a team surgery where ENT or a neuro-otologist does the approach, and then once you get there, the neurosurgeon removes the tumor. Another thing that's not infrequent is pathology called otosclerosis. This is where you can kind of think of it like Paget's disease of the bone, but where there's a lot of bone remodeling that occurs in the middle and inner ear area. And unfortunately, sometimes that can cause fixation of the tiniest bone in the body, the stapes. And the stapes' job is to vibrate in and out as sound comes in, vibrates the tympanic membrane, all these little ossicles vibrate, and that sends the sound waves into the cochlea so we can hear. Well, you're going to get some conductive hearing loss if this can't vibrate. And so we'll do there's multiple approaches to treat otosclerosis surgically. It is a surgical disease. And this is an example where they removed most of the stapes superstructure, and then they put in a prosthesis that's chilling here on the incus, and it will move in and out of the inner ear to improve hearing. Lots of times when you are doing ear surgery, you are using a drill. You'll be using a microscope to get good view, and you'll be drilling around a lot of critical structures. So you'll be drilling up here, would be the tegmen, where you pop through here, you see the dura and the temporal lobe. Over here, you have the labyrinths, where if you busted in here, you would get into the inner ear, and so you could permanently kill the hearing in their ear, and they would be very dizzy. Along here's the facial nerve. And so this is going through the facial recess to get into the middle ear. When we're doing things, you mess up by a few millimeters and you can leave the patient with a paralyzed face or with no hearing, etc. So it's delicate surgery. And this is an example of a cochlear implant. Maybe ophthalmology is getting close to this, but currently we're the only specialty that can restore a damaged special sense, and it's pretty cool to take a patient that is deaf or near deaf and then restore that hearing. If you ever need a pick-me-up, just YouTube some videos of patients that are having their cochlear implant turned on and see how magical that is. And then sometimes, depending on the area, this is a skull-based tumor that a lateral skull-based surgeon might assist with. So now on to rhinology and anterior skull base. Some of the things that you might be doing is you'll see people with sinus disease. Here's a sinus that's pretty filled with air. This is a CT scan, so black as air. You can see this left maxillary sinus is full of stuff. So you're seeing patients that have sinusitis and sinus problems. Either facial plastics, rhinology, or generalist can treat you for a deviated septum, and this can cause turbulent airflow through the nose that can cause the mucosa of the nose to change and alter itself, and the patient might have difficulty breathing through their nose with what's called nasal obstruction. So we can fix that with fixing their deviated septum. This is an example where the mucosal structures within the nose might be too big, and you can go in and take out some of this stuff so they can breathe better through their nose. In rhinology, this is an example of, here would be a pituitary tumor, such as just a pituitary adenoma. And you can go through the nose, pop into the sella, and remove this tumor, typically done with a neurosurgeon, but ENT can do the approach. And then this would be an example of somebody with good old Graves' ophthalmopathy, where they've got too much retroorbital soft tissue, and so they go in through the nose and decompress that orbit, and so their eyeballs aren't sticking out anymore. And this would be a cancer case where they did a total rhinectomy, and then you can go get a fake nose to kind of hang on there, etc. Lots of other stuff that goes on in rhinology. Laryngology and voice. This is one of my favorite voices of all time, Freddie Mercury, the lead singer for Queen. And so if you want to see most of the singers if you find singing to be fascinating, then this is a good field for you. Interacting with that physiology, where you look down at the vocal folds and you can see all sorts of different kinds of pathologies. Sometimes people have paralyzed recurrent laryngeal nerves. And so what that would mean, if let's say this side was paralyzed, then you could not adduct this vocal fold or bring it in, because it's when the vocal folds are together and touching, and then you push air out through them, that they vibrate and create sound. And so sometimes we'll go in and inject them with different types of fillers so that it would medialize this vocal fold, and then somebody could talk or phonate better, or when they're swallowing, maybe they don't aspirate as much or at all. You can also, that would do something, as it's a filler, most of them are not very permanent. Sometimes you can do a thyroplasty, where you take something and you put it through the thyroid cartilage and stuff it in this space next to the vocal folds, and then that permanently will medialize your vocal fold to improve someone's voice. Sometimes you might have an injury to the recurrent laryngeal nerve, and you can take something like the ansa cervicalis in the neck and plug that in to the damaged recurrent laryngeal nerve and give some tone to a paralyzed vocal fold. And then they also do crazy things where, let's say you have some subglottic stenosis or tracheal stenosis, you can cut out that section of the trachea and then reanastomose the things, which is a pretty crazy surgery because the complete airway is open. I'm sure it's anesthesia's favorite case. You can go into pediatrics. So, the basic things would be looking in, and a child has ginormous tonsils. The main indication for this used to be that they had too many tonsil infections, sore throats, and they take it out. We don't take them out. It's a pretty strict criteria for removing tonsils for that nowadays. So more often, it's actually that in kids, because their tonsil is so big, it's starting to cause sleep apnea, and so we can fix that by removing the tonsils, or at least improve it. Here's a eardrum, and we've put a tube in. Lots of times as kids, before their eustachian tubes have matured, which is the connection between the ear and the back of the nose / top of the throat, they need tubes to help them equalize those pressures and not get infections. Here's an example of laryngomalacia, where sometimes children are born with a floppy larynx, and so they have stridor or noisy breathing all the time. Most of the time we can just observe them and treat them with a few medicines, but sometimes we do surgery for that. You can have kids born with microtia and fix their ears. And you can have kids born with lymphatic malformations and remove those. And then, while plastic surgery at most institutions is who's doing the cleft lip and cleft palate, certain ENT programs do this. And if it's your jam, you can totally get into it through the realm of ENT. Head and neck surgery or surgical oncology in the head and neck. You're dealing with tumors and different tissues of the head and neck. So this would be a ridiculous extreme example, of which I've never seen one so extreme, of a parotid tumor in this woman. And this is where you would go in, and the difficult thing about parotid surgery is that this nerve, the facial nerve, runs through the parotid, and so it's a very delicate surgery to remove things out of the parotid gland, because if you're not delicate and careful, then you can leave them with a paralyzed face. You deal with thyroid surgery and parathyroid surgery, and so, this may be a thyroid cancer, and you can remove that, or say this was simply a goiter or a thyroid nodule that was making it hard for this patient to swallow or making it feel difficult for them to breathe. Parathyroid surgery, you're dealing with patients with hypercalcemia and the physiologic effects of that, and you can cure that with taking out one or more of their parathyroids. This is an example of taking out somebody's entire larynx or voice box, total laryngectomy. And then what ends up happening is they have a permanent hole for breathing and a permanent hole for swallowing. And this is one way to treat laryngeal cancer that's higher in stage, as you can also, of course, go with chemoradiation. But sometimes if things recur after chemoradiation, then the total laryngectomy is the way to go if they want to keep treating their cancer. This specimen would be an example of a total or a maxillectomy with an orbital exenteration. We can see this would be somebody's left maxilla, where you can see everything from their teeth and their maxilla up into their eyeball from their orbit. So when you take out these big cancers, you oftentimes are left with a big defect. You can't just leave a big hole in someone's face and neck. So you need to use very often flaps to reconstruct it. Historically, this was almost always done by plastic surgeons, but kind of like how radiologists figured out how to do interventional cardiology and then the cardiologist stole it, more or less ENT is stealing this, even though it was pioneered by plastic surgery. Very often you can go into a head and neck cancer fellowship and also learn how to do these flaps. So this would be an example of somebody whose tongue was resected. This would be the healthy tongue, and then they resected this half, a hemiglossectomy for cancer, and then they can take somebody's forearm kind of skin and soft tissue, radial-free forearm flap, and then they'll use that to provide bulk to the tongue. This is nice because then this still has muscle, and the muscle of this tongue can move the entire volume of this reconstructed tongue and hopefully avoid having any trouble swallowing and dysphagia or issues with talking. This would be an example of a cancer that's growing and infiltrating into a patient's mandible. And we would resect this. So here's a patient, here's their nose, here's their tongue, here's their top teeth, their maxillary teeth. And then you can take their fibula, the smaller bone in their calf area, and take a flap with the blood vessels going to it, and then under the microscope plug these blood vessels into blood vessels in the neck and create a new jawbone. And here's an example of a complete maxillectomy where they then use the fibula to reconstruct the patient's midface. So he still looks pretty normal. Other places will just put a bunch of muscle in this defect. Other places will take the inferior portion of the scapula to rebuild the midface. And then you can also go into facial plastics. Some facial plastic surgeons do those flaps that were mentioned on the last slide, and then some of them will focus more on cosmetic things. So this young woman was born with a somewhat of a dorsal hump, and she didn't like her dorsal hump, and so we were able to straighten it and have what some would say is a more aesthetically pleasing nose. This guy has some insane ptosis, or drooping of the tip of his nose. Very unfortunate, but was able to be fixed with a good old rhinoplasty. You can also do a lot of, things like facelift, etc. So this woman has some pretty intense platysmal bands in her neck. We can see she's got a lot of droopiness. There's a fancier term for that, but I'm a young resident, so I don't know it yet. In her infraorbital fat pad areas, and she's got some wrinkles, and so you can do a blepharoplasty to fix those, a facelift to lift everything up here, and a neck lift to work on these things, or put some Botox in the platysma to relax those platysmal bands, etc., etc. Here's just another example of somebody before and after getting a facelift. Where they had wrinkles and now they don't. The fancy word for this is rhytidectomy. Rhytid refers to wrinkles and ectomy refers to removal. Here's a blepharoplasty where they're doing eyelid surgery to give a more youthful appearance and less tired appearance. And then there's also facial reanimation. This woman, unfortunately, you can see that she can smile on this side. She can kind of start to close her eye on this side. Everything is completely relaxed here on the patient's right side. And it's unfortunate because if somebody tells a funny joke and she smiles, she looks a little bit deformed because of that. And so there are different procedures that one can do to, take a gracilis or other bits of muscle and up in here and do nerve grafts and all sorts of things to try and make them a little bit more normal appearing. And this would be an example of somebody that had skin cancer on the tip of the nose, usually removed by a Mohs surgeon. And then you can do a paramedian forehead flap where you actually take a chunk of skin from up here with one of the arteries coming out of the orbit. And then you actually swing that pedicle down, as we see here. It's down here, and then you put it on the tip of the nose. And you leave it here for a certain amount of time, so that this can kind of grow roots This tip here can grow roots into the nose of blood vessels, and then eventually you can resect this pedicle, and you would never have guessed that this man had a gross hole in the tip of his nose, as it was repaired with a paramedian forehead flap. Kind of a newer field within ENT is sleep. When I say sleep, I'm mostly referring to sleep apnea. So some people, they're snoring a bunch and they're getting obstructive sleep apnea at night because they have way too much tissue back here in the oropharynx area. So you might do a UPPP, a uvulopalatopharyngoplasty, where you go in, you remove their tonsils, and then you remove their uvula and a certain amount of their soft palate and kind of stitch these tonsillar pillars together and all of that up. And that might open up their airway so they snore less and they stop breathing less often when they're sleeping. Sometimes it might be that they have a really big tongue base. So this is a kind of a picture showing that here's the anterior tongue that you and I are used to seeing. And then the anterior 2/3 is separated by the posterior 2/3 by these viae papilla. And back here, these are the lingual tonsils. Just like our palatine tonsils can be hypertrophied and big, these can be huge, and you can go in. This is an example of using the robot to go in and resect a bunch of this tissue, and that might help a patient breathe. This is the epiglottis chilling back here, down by the larynx. Here, again, it's using the robotic arms to go in and remove some of that to help somebody have worsen their, decrease their sleep apnea. And then this is the new bee's knees. This is a diagram kind of representing a hypoglossal nerve stimulator. So the hypoglossal nerve comes out of the skull base and innervates pretty much all of the muscles of the tongue. And very often when patients have sleep apnea, it's because the back of the tongue is relaxing and falling to the posterior wall of the pharynx, and so air cannot get in, and they are apneic. So the goal of this surgery is to take a nerve stimulator, find the branches of the hypoglossal nerve that go to the genioglossus, genio referring to this chin area of the mandible, glossus referring to tongue, because when those fibers contract, when the fibers from the base of the tongue to the chin contract, it pulls the bulk of the muscle forward, opening up the airway. And so then that nerve stimulator is connected to this thing, and this thing goes into the between the external and internal intercostal muscles, such that this sensor, every time you breathe, it sends a signal, boop, 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 and it goes and tells the nerve stimulator to activate and move the tongue out of the way. So a patient, before they go to sleep, they'll wave a magic wand over this sucker, and that'll make this turn on in about 30 minutes, giving the patient time to fall asleep. And then every time they take a breath, it synchronizes pushing the tongue forward a little bit so that the sleep apnea is cured. And that is called the Inspire, or the hypoglossal nerve stimulator. And then I think this is the last one I'll mention, CMF trauma. So CMF trauma can be treated by an otolaryngologist. It can be treated by a plastic surgeon, and also lots of times oral and maxillofacial surgeons, which is a surgical specialty of dentistry, can get into this. So some of the things we might see, this is a 3D reformation of a CT scan showing a nice mandibular fracture, where you'd go in and put some plates on here. So while we do a lot of other stuff that's pretty delicate, sometimes we play orthopedic surgeon with big tools. And this would be an example of, here's a patient where this is kind of a normal orbit on this side, and then here on the patient's right, you can see the orbital floor should be just right here. Boop. But you can see all of this stuff that has blown out below the orbit. So that would be a blowout fracture. And you can go in and fix all the fractures out here on the zygoma that might be associated with that or whatever else, and then also fix the orbital floor after you reduce the contents that are herniated down into the sinus back up into the orbit. You want to do that because what you might happen if you don't is you might get enophthalmos, where the eyeball on this side is a little bit more forward than the eyeball on that side, where essentially the patient lost some of the volume in his orbit because it blew out, and so the eyeball goes a little bit further back, and then this patient will have diplopia or double vision when he looks in a lot of different areas. And then you also might get some of the crazy fractures. These are the Lefort fractures, where somebody gets a super high velocity blunt impact injury to their face. And more or less, if you were doing the physical exam, you could grab their upper teeth, their maxillary teeth, and just shake it. And it would be free of, if it was bilateral, it would be free of the kind of the neurocranium up there, where the viscerocranium can just become completely loose of the neurocranium. And you go in and put a bunch of plates and screws in there. Another nice thing to mention is you get compensated pretty well. So this is the Medscape 2020 survey about compensation, and ENT comes in at number 3. You'll notice neurosurge isn't on this, so I'd assume neurosurge would be number 1, but not sure if not enough of them responded or whatever else. But it's nice to know that you get compensated for doing really fun things, and you can pay off those med school loans. If you're interested in learning more as a med student or undergrad or whatever, a couple websites are commonly used by people interested in ENT. HeadMirror has a lot of information that's put up there. It can tell you what you should do as a med student to prepare for being competitive for application, what things to do during residency, and has connections to other stuff. Otomatch is kind of like the student doctor network of ENT applicants, where you can go on and find a discussion chat to learn more about it. And then feel free to follow me on Instagram, Oto with Jimbo. I'm trying to become a better artist because I think art is cool, and that was a weakness, and I want to try and make it a strength. So I do a lot of sketches and try and get better at that and do a little bit of teaching. I think otolaryngology is phenomenal. I'm one of those people that went through med school and probably would have been happy in everything. I think the only thing I didn't really love was neurology, although I do love certain aspects of neurology, and I'm happy that I get to do lots of that with ENT, interacting with the cranial nerves. But anyhow, it's a super fun, it's a subspecialty, but still very broad, and I've been very happy with it so far, even though I'm only just about done with my intern year. So please leave any comments, and sorry for any imperfections or mistakes that I would have made, but hopefully this was informative to people interested in the field.